All right, next speaker is John Canelopoulos. He's going to talk about some crazy complications and how to manage them.
I didn't know if the crazy was for the complications or for me, but I'll take that as a compliment. Thank you for having me. Good morning. We'll be discussing more about topography-guided treatments on these eyes later on today. These are my financial disclosures. And we worked with a lot of technologies since what unfortunately is approved in the US. Now I say unfortunately because the technique and technology has moved along to higher fluence, to not using, crazy. Yeah, for not using dextran diluted riboflavin, which is the go-to through the FDA approval. In current protocols, we use 6 milliwatts for CXL and higher fluences for it combined with LASIK or epithelium on. My go-to procedure does combine a very mild PRK, and I hate the term PRK because it alludes to refractive surgery. This is the PRK, top left, which is basically an attempt to normalize the cornea. So thus, although there are alternative treatments, CXL alone, gas permeable lenses, we're seeing a lot of scleral lenses in Europe that have become very affordable and extremely well tolerated in our country, where there's a lot of sand in the environment, and RGPs are usually very difficult to tolerate. So that's a nice venue now for these patients if they're stable. Intracorneal ring segments, we might see more work on allograft inlays, lamellar and penetrating keratoplasty. But as far as early complications were similar for CXL alone and our combination treatment, obviously the biggest problem is postoperative pain. We've seen immune intrastromal ring, which is probably attributed to the bandage contact lens use. All these cases have delayed epithelial healing, so don't treat these cases like your routine PRK patients or like a routine case that the cornea is deepithelialized. The treatment kills keratocytes to about 300 microns depth. So there's a lot of inflammatory component within the cornea, and this manifests on the surface of the cornea. These are external disease patients for 3 months. And I want to underline that we've seen Saltzman-like epithelial scarring, which kind of underlines the epithelial hurricane. This is what an immune ring looks like, and this could be 360 degrees around. Obviously makes you very worried. Take off the bandage lens, heavy on the steroids. This is delayed epithelial healing, and this will be more typical. This could be day 5 or day 6. So key for me here is to hold off on the steroids. We use routinely autologous serum in these combination patients, and maybe if this persists, go on something that's more radical for reepithelialization, such as tetracycline type medication or even topical progesterone. This here needs to be scrubbed off, in my opinion. You see that little ring of necrotic epithelium. It's created almost a crater. This is not going to epithelialize. It does not allow epithelium to come in and cover over. So this, in my opinion, needs to be scraped. We've seen some delayed epithelial healing in our cases. So this is not your typical 3 to 4 day PRK. You can see they can go out to 10 days. And this is what I describe as a hyaline deposit. It's a Saltzman-like nodule, which underlines that the surface of the cornea is unhappy. And this is definitely not something you want to co-manage and see a month later, because the patient may come in with a severe cornea scar and you're trying to avoid a transplant for keratoconus, and you may drive yourself into a transplant for a severe cornea scar. This is what I see more typical, the stellate epithelial structure, which usually goes away with a bandage contact lens, lubrication. But if it persists, I will go in there with a Q-tip and I'll gently try and rub it off. Of course, the epithelium is very fragile in these cases, so you may try to just rub off the tip and the whole epithelium will come off. So then you're back to square one. Again, lubrication, bandage lens, autologous serum. In my cases, the combination cases, everybody gets that. I'm the CXL Dracula in Athens. Everybody gets blood drawn. Hold off on steroids for a few days. These cases do need long-term steroid medication, and I remind you that we published that keratoconic eyes probably have a higher incidence of steroid-induced hypertension. So you have to be aware of that. Difficult to measure pressure on those eyes. You have to employ your best skills and your best armamentarium to make sure that at month 1, these thin corneas don't have pressures of 40. And remove this with a 30-gauge needle. Please go sideways. Don't go vertically on the cornea. Patients can always sneeze, or a Q-tip. Late complications, we've seen subepithelial scars, stromal haze, ectatic progression, as we talked about before, and overcorrections. Be aware of this. You're young in this path, especially our U.S. colleagues. you're going to see some remarkable results a decade out, and I'll share some with you. This is a mild subepithelial cornea scar. It's great because it flattens the cornea even more, but obviously it does have a toll in the visual performance of this patient. This is something you want to avoid. This scar here is almost mirroring our topography-guided normalization, and this is why we use mitomycin at the combination treatment, partial topo-guided and CXL. This is a diffuse stromal haze. It kind of looks like the scar that people who go to very high altitude and had PRK get. It's deep stromal scarring, which tells you that keratocytes come in 3 months after CXL procedure, but they're quite active. They're on steroids, so you have to be very careful to recommend to your patients, especially those who do a lot of outdoor activity, to protect themselves from UV light. This is an intrinsic complication for CXL, and we've seen it more. I'll show you a slide in pediatric patients. Obviously, taking off the epithelium may carry risk of infectious keratitis. You can see a little hypopyon building up there. And what I fear the most of all these complications is this. Although CXL is supposed to stabilize the cornea and make it more resistant to enzymatic degradation, and we've actually published to use it as an adjunct with the vehicle cornea and keratoprosthesis. And there's a multi-center study in the US now, sponsored by the Department of Defense, believe it or not, on using CXL on the vehicle cornea for keratoprosthesis. And these eyes are sick eyes that the cornea usually melts. Nevertheless, you can get cornea melt from the procedure itself, from some immune reaction. We have a patient that we're treating now, 10 years after CXL, all of a sudden, spontaneously, the cornea started to melt. Of course, it may not be CXL, it may be an immune, systematic immune problem that has ignited that. Everything looks good here, top left, keratoconus patient, referred to Dr. Kanellopoulos for cross-linking about 10 years ago. 1 year, everybody's congratulating each other. We have a 2020 patient. The disease, we used to call it regressed, although this is a marked refractive effect of the CXL procedure. 5 years later, maybe we did a little bit too much. And this is 10 years later, and you can see this is almost 20 diopters flattening, and this is with the Dresden protocol, and we have since 2005 stopped using the dextran diluted riboflavin and have gone to a saline diluted because it dehydrates the cornea very much and it creates significant cross-linking differentials within the cornea. Remember when I spoke about that cross-linking demarcation line on your OCT, some of us can see it on the slit lamp. I have a difficult time seeing it there. That has to be kind of uniform. If it's really diving in the center of the cornea, then you know you have a cross-linking differential, and that central cornea is going to be refractively active. It will flatten through the years. That's the pearl I have to share with you. This is one of the two identical twins I treated, I think it was in 2010. Everything was perfect. 2 years later, I want to underline that, this young boy got a job at a beach and came to us in September looking like this. So we've seen this in 3 pediatric patients. We actually reported our pediatric data in this meeting, and I think it's an intrinsic complication for young patients, and this is several months later with steroid use, but obviously you do not use them. You do not want to use that much steroids in such a young patient. Something to be aware of. Unknown potential risks, obviously, we do not know the long-term ocular surface disease, meaning the limbal stem cell damage that this does. Theoretically, UV light can cause conjunctival squamous cell carcinoma. We do not yet know the long-term endothelial cell toxicity, although short-term it doesn't seem to be that bad. How much this is going to augment cataract formation in younger age. And it does, of course, interfere with intraocular pressure measurements, and there's no formula out there to calculate the thin but more rigid cornea. So underline, if you have glaucoma suspects, please pay attention to the optic nerve and forget about the intraocular measurements if they're normal. I know that we have to cross-link early, that's what everybody says, but we have to be aware, not every regular topography needs to be cross-linked, because as you saw, it's a procedure that does carry some complications. I do want to repeat, document progression efficiently, and I cannot stress enough how epithelial mapping is a game changer on this. Having accurate stromal thickness measurements, which we have published that the OCT is more accurate on, and having the ability to look at the epithelium is a game changer as far as who's active, who's inactive, who's stable, et cetera, et cetera. Covered all this with our protocols, and if you have not made your June plans yet for this summer, come to Mykonos. I'm not running this meeting, but I'll be there. We have an officer who'll be happy to see you. Thank you very much for your attention.
John, can I ask a quick question?
Yes.
So one question that always comes up, very common, is what's the risk to the limbal stem cells with cross-linking? Do you need to protect them, or is that really a risk or issue you've not seen as a problem?
Well, there's literature. I know that Hafesi has reported in ex vivo that there's very little damage when you concentrate on the center of the cornea. But clinically, the response that we're seeing on the surface really underlines the fact that there is some hardship at the limbal stem cells. I mean, delayed epithelial healing is a challenge to limbal stem cells. So I think it's a very gross procedure. Usually our technicians do it. So I would strongly encourage to cover the limbal stem cells if you're not on your own watching the patient throughout that whole fantastic half hour.
John, I have a quick question as well. So that dramatic progressive corneal flattening really got my attention. Is that a one-off case that you saw, or do you think that's the tip of the iceberg?
It's not common, John, and it's a very good question, but it's not uncommon either. I mean, I'd say with the older technique, it was 1 out of 30 patients. And it has, in my mind, I can almost read this on OCT because the thinnest cone cornea is extremely dense, hyperreflective, and you've had most of the cross-linking there. And actually, we're trying to reproduce this when we do refractive CXL outside the U.S. We're trying to use pattern CXL, cross-link areas of the cornea more, other areas less, to get a refractive change on virgin eyes.
So what is difference between the older technique and what we have available in the United States now?
I think that the fluence of light, going to higher fluence, not necessarily 30 milliwatts, but 6 milliwatts, and staying with the same energy, which is 5.4 joules, may help, and also the riboflavin solution. Dextran diluted riboflavin dehydrate, this has been reported in the literature. Quinones and associates have reported several papers on this. Dehydrates the cornea. So if you measure your cornea right before you start, it'll be about 30, 40 microns thinner, and obviously be thinner over the cone.
How do you protect the limbal stem cells?
You can use one of those circular sponges to put over. You can use your hand tree fine of 9 millimeters to cut some nice paper and put it over.
Did you do that routinely?
I don't do that routinely because our cross-linker has a tracker, and we feel very safe about it being exactly the area that's going to be treated.
All right.
Yes.
John, if you're Dracula, I understand the facial hair now that I mentioned yesterday. I'd probably disagree on the limbal stem cells. I think that the production of hydrogen peroxide in type 2 reaction and type 1 reaction is what makes these eyes sick. As you said, there's corneal apoptosis 10 to 300 microns. These are sick eyes that we're treating, and in the paper by Ricoz, R-I-C-H-O-Z, I don't know how to pronounce it, and a few others, there have been some really strong refutations of the original thinking on limbal stem cells. So while I agree that these eyes can be quite sick and have problems, I don't think that I can comfortably attribute that to limbal stem cell damage.
Well, it's a good argument. Empirically, and we reported several papers on this, following reepithelialization, epithelial remodeling, it takes a year for these corneas to get that 50 micron epithelial thickness. So that, in my mind, clinically is a hardship to the limbal stem cells.
And I think we're talking apples and oranges because that's epi-off.
Yes, correct.
All right.
Okay, thank you.
Fantastic. Thank you so much.